Now that we have defined behavioral and mental health and described the impact community health workers can have in connecting people to treatment, let's dive deeper into understanding the disease process behind the top identified behavioral health concern in Rhode Island, substance use disorders. The official terminology used for categorizing and defining substance abuse and addiction is substance abuse is the use of alcohol or drugs despite negative consequences. Addiction is a chronic, often relapsing brain disease that causes compulsive drug seeking and use despite harmful consequences to oneself and others. Then substance use disorder is the dependence on or abuse of alcohol and/or drugs, including the non-medical use of prescription drugs. But let's stop and talk about official terminology used to define things. We mentioned stigma in the last narrated presentation, which has a role in how we really look at the terminology we want to use as community health workers. We know that we don't want to use jargon because we want to increase understanding, but especially when it comes to substance use disorders, we want to make sure we're not correcting the client's terminology. It's the language they are comfortable with, so you should adapt to it, not the other way around. For instance, as you saw at the beginning of this presentation, we were presenting this as substance use, but in the official description, it's substance abuse. The use of that word abuse can have a negative connotation to it, which is why we see people using different terminology in different situations. So the thing is, if you accidentally say something that doesn't resonate with your client, be prepared to apologize sincerely. This could happen at a time that you really don't expect. But as long as you are sincere and willing to correct yourself, most people will accept your apology. Alcohol is a substance that's commonly associated with substance use disorders. Symptoms of alcohol use disorder include drinking more or longer than you intended, wanting to cut down or stop drinking or tried to but couldn't, being in situations while or after drinking that put your or someone else's health at risk, needing to drink more and more to feel the effects, continued drinking even though it makes you feel bad or adds to another health problem, having a memory blackout, spending a lot of time drinking, being sick or getting over other after effects, continuing to drink even though it causes trouble with your family or friends, drinking or being hungover interferes with home, family, job, or school, giving up or cutting back on important and fun activities in order to drink, getting arrested or having legal problems because of drinking, having withdrawal symptoms such as trouble sleeping, restlessness, nausea, sweating, a racing heart, confusion, or seizure. Now notice how many of these symptoms come from the client's perspective. Don't be looking for warning signs and making assumptions yourself. It's really your job as a community health worker to ask tough questions sometimes to get the answer in your client's own words. Take a moment to pause and review the National Institute on Alcohol Abuse and Alcoholism guidelines for binge drinking. Then think about, as a community health worker, is this information and the way it's presented useful to you in the actual education and empowerment of the clients that you work with? Would this help somebody to be able to make choices that would improve their health and their health outcomes? Is there a better resource that you know of that could be used to communicate this information? These are all things you want to think about when looking at these national guidelines and thinking about how you're going to actually implement your practice as a community health worker. Binge drinking, or the acute consumption of a higher than safe level of alcohol, results in 79,000 deaths in the US each year. It's the leading preventable cause of death. More than 15% of US adults report binge drinking. So it's not just an individual problem, it's a community health problem because it can lead to motor vehicle crashes, violence against others, the spread of HIV and sexually transmitted diseases, unplanned pregnancy, fetal alcohol spectrum disorders and sudden infant death syndrome, and alcohol dependence from either the consumption of it itself or the impact on people's mental health. Heavy drinking, or the more chronic consumption of alcohol, is 5 or more drinks within 2 hours on each of 5 or more days in a month. Heavy drinking results in 88,000 deaths each year. Most heavy drinkers will die 30 years younger than they otherwise would. Most heavy drinkers are not alcohol dependent or addicted, but that does not mean they are not at risk for addiction. Both binge drinking and heavy drinking are serious health risks, so we want to continue to educate and help empower people to make choices that will improve their health. We focus on binge drinking and heavy drinking as the more dangerous alcohol consumption behaviors. We also want to focus on low-risk drinking for the opportunities in education and prevention of substance use disorders. So low-risk drinking is defined for men as less than 4 drinks on a single day or less than 14 drinks per week, and for women as less than 3 drinks on a single day or less than 7 drinks per week. At this point, the question often comes up, why is it different for men and women? Is that in itself a form of discrimination? The answer is actually no. There are physiological differences in the way that men and women process alcohol, so that's where those numbers come from. There is no safe drinking advised when you're driving a vehicle or operating machinery, when you're pregnant or trying to become pregnant, when you're taking medications that interact with alcohol, and when you have a medical condition that alcohol can aggravate. That being said, there is no amount of alcohol drinking that is truly considered as a safe amount. To better understand the relationship between substance use and mental health, we need to look at comorbid or co-occurring disorders and how they relate to a person's overall health. Comorbid, co-occurring disorders are 2 or more disorders or illnesses occurring in the same person. They can occur at the same time or one after the other, and it involves interactions between the illnesses that can make both worse. So why do substance use and mental health disorders often co-occur? They exacerbate each other so much that people most impacted by one will often be impacted by the other. In fact, people addicted to drugs are roughly twice as likely to suffer from mood and anxiety disorders and vice versa. Further evidence for why we need to regard mental health disorders with the same professionalism and seriousness as physical illnesses is because people with mental health disorders die earlier than the general population and have more co-occurring health conditions. 68% have 1 or more chronic physical conditions, and 1 in 5 have a co-occurring substance use disorder. So is drug and alcohol addiction a mental illness? Yes. Addiction changes the brain, compromising normal priorities and substituting new ones connected with getting and using drugs, weakening the ability to control impulses, even with negative consequences, and is similar to features of other mental illnesses. Addiction is not laziness, a bad habit, or a choice. It's a disease. We have an opportunity as community health workers to demonstrate a new benchmark of respect and dignity in this practice.